about to say you just felt like freezing with us.
No, it's just cold. All right. Thank you, thank you. Can everyone hear me okay? We good? Okay. Fallen. All right, so we're gonna go over neuro today. A couple of things before I jump into that. So I will get your exam grades posted after lecture today. And if you need to remediate, please reach out to Miss Easterly and I, preferably before the end of the day, because that way, since our schedules are hopefully pretty open tomorrow, we can try to do some remediations if we need to. And as always, I'll do my usual spiel. If you did not get the exam grade that you wanted, you are not defined by an exam grade. It is okay. We will talk through it, but I don't want you to feel like if you didn't do well, that it means you're just failing. That's not the case. I know we're at a point in the semester where everyone's getting tired. We're kind of getting to the end where we're chugging through the last few weeks of content and we're starting to get a little bit burnt out, definitely feeling ready for Thanksgiving break and winter break. So just hang in there. Keep taking it one day at a time. And I'm always here if you just need to complain or if you have any questions or if you need a shoulder to cry on, like just reach out to me. I'm here for you. So I will get those exam grades posted at the end of lecture today. And then the other thing I wanted to go over before we started lecture was I posted an announcement about this yesterday, but wanted to talk about it again in case anyone has any questions. So for clinical next week, when we were calculating your clinical hours for this semester, you'll be doing your psychological first aid training on November 12th. I believe it's a Wednesday, on the Enid campus. So that is your service learning component of the course, and that's also going to be on the day of caring. So we didn't realize that for that psychological first aid that we knew there was a training module that you did beforehand. We didn't realize that training module takes like 5 hours, supposedly, approximately 5 hours. So we want to make sure that we are giving you clinical hours for the time that it's going to take to complete that, which is why we are now making these adjustments to the clinical schedule. So next week, it's our last clinical of the semester, but unless I've told you otherwise, next week you'll be leaving clinical at 11:30. That includes if you're also at like one of the GSP clinics, like you'll go ahead and leave for the day at 11:30. So do your best on your clinical paperwork for that day. I know that we'll be kind of limited on time, so I've communicated with your clinical instructor that there's going to be a little bit more leniency with grading. You definitely want to make sure that you're getting in a patient assessment. Of course, we want to do that within the first hour anyways, so getting your assessment, pass your meds. We're definitely going to do a care plan since you're going to know what your patient's diagnosis is. But try to work on those items, do the best that you can. But if for some reason, like you can't get all of their labs or all of their medications before we leave for the day at 11:30, that's okay. Just do what you can. There will be a little bit of wiggle room there when we're grading that. So, and then another thing to consider is that if you still need to do your checkoff for holistic assessment, your full head to toe bedside assessment, make sure you are doing that before we leave for the day. So, any questions in regards to that? Everything makes sense? Oh, I'm getting thumbs up.
I have a question.
Yeah.
Where do we access the 5-hour module thing? Is that gonna be posted somewhere? Is it already posted somewhere?
Yes, so that's a good question. So Dr. Ritchie posted that in the nurses station. There's a link to it. I want to say it's like a few announcements down. So if you go to that nurses station, Dr. Ritchie made an announcement detailing the day and what to expect from the link as well. Any other questions?
But I didn't hear that question. What'd you say?
Just asking where to access the module
Oh,
for the pre-training module for the psychological first aid. Yeah, it's a link on the nurse's station. Yeah. Any other questions about that? Okay. Alrighty. And I will say my community students did this last year. And I mean, the module says it takes 5 hours. I don't remember most of them saying that it actually took a full 5 hours, but please, on that clinical day or just at some point, take that time to get that done and make sure it's finished before we do the psychological first aid training on November 12th. So, all right, let's dive into the nervous system here. So for this first chapter, we're just going to be looking at how do you perform an assessment of the neurological system, and then how do we identify when the patient is at risk for developing health problems related to their neurological system. So before we really dive into these neurological disorders, let's do a quick review on how the nervous system is organized and how its cells function. So this will be a little bit of a patho review. The nervous system, it's responsible for cognition. So it's responsible for how we think and process information. And it's also responsible for our sensory perception and our nerves and our mobility. So all of these things are critical to understanding how certain conditions like a stroke or multiple sclerosis will affect the body. So whenever we're having issues with our neurological system, how that affects the body. The nervous system is divided into two main parts: the central nervous system, which includes our brain and our spinal cord, and then also our peripheral nervous system, which consists of all the nerves that branch out to the rest of our body. The central nervous system acts as the command center, while the peripheral nervous system delivers messages to and from the body, kind of like a communication network. So the primary functional cell in the nervous system is the neuron, which can be a sensory neuron. And so a sensory neuron brings information to the central nervous system, or it can be a motor neuron, which sends commands from the central nervous system to our muscles and the rest of our body. So each neuron has a cell body, or a soma, which contains the nucleus, dendrites that receive signals, and also an axon that sends signals to other cells. So we also have neuroglia, also called glial cells, which don't send signals themselves, but they help to support, protect, and nourish the neurons. So looking at our central nervous system, like I mentioned, that includes the brain and the spinal cord, which really act as the body's main control center for all of the neurological activity. The brain can be divided into three key regions. So the forebrain, the cerebellum, and the brainstem, which are each responsible for different functions. The forebrain contains structures like the cerebrum, which controls higher level thinking, memory, emotions, voluntary movement. So when a patient has difficulty speaking or remembering after a stroke, it usually involves a forebrain injury. The cerebellum is responsible for coordination, balance, and fine motor skills, which is why cerebellar injuries can cause unsteady gait or difficulty performing smooth movements with your muscles. The brainstem is the most important part of all of this. So it controls that automatic life-sustaining functions like your heart rate, breathing, blood pressure, level of consciousness. So if you have an injury to your brainstem, that's going to be life-threatening because it controls all of those really essential functions. The spinal cord really serves as that communication pathway between the brain and the rest of the body. So it carries motor signals downward and sensory information upward. So as nurses, when we assess neurological function, we are really evaluating how well these different regions of the central nervous system are working together. So looking at our peripheral nervous system, this includes all of the nerves that branch off from the brain and spinal cord to the rest of the body. It has three major components: spinal nerves, cranial nerves, and the autonomic nervous system. So spinal nerves exit from the spinal cord and are responsible for carrying sensory information to the central nervous system, and then motor commands back to muscles for movement. Cranial nerves originate in the brain and control functions like facial movement, vision, hearing, swallowing, smell, so our senses. And those are assessed in a neurological exam, as you guys know from holistic assessment, especially in patients with a suspected stroke. We're assessing these things. So the autonomic nervous system regulates involuntary processes like heart rate, digestion, respiratory rate, without us even thinking about it. And then you've of course heard of, within the autonomic nervous system, we have our sympathetic nervous system, which prepares our body for that fight or flight response. So it increases heart rate and blood pressure and controls those systems in our body. While the parasympathetic nervous system promotes rest and digest functions. That's a good way to remember that, rest and digest. So it lowers your vital signs, promoting relaxation, digestion. So understanding those divisions helps us interpret patient symptoms and anticipate how the nervous system responds to stress, illness, and injury. So as patients age, their nervous system naturally undergoes changes that can affect mobility, sensory perception, and cognition. You've probably seen some of this in the patients that you've been taking care of in the hospital during your clinical experiences. So in these elderly patients, their neurons can shrink or lose how efficiently they communicate within the nervous system. So our reaction times slow down, nerve conduction becomes less rapid. And this is why with our older adults, we usually see them moving more slowly and they can be at that higher risk for falls. Sensory perception also declines as our patients get older in age, especially with areas like vision, hearing, and touch, which of course can impact how they detect pain or changes in temperature. And then from a cognitive perspective, mild forgetfulness or slower information processing, that can be a normal part of aging, although it should not be confused with like dementia, Alzheimer's, or other pathological conditions. And we'll dive into those a little bit more and how to distinguish between just expected changes with aging versus when it's more serious, like with Alzheimer's or dementia. So looking at motor changes, those can include decreased muscle strength, reduced balance and coordination, and we can also see some tremors in some individuals. And so because of these changes that we see in our elderly patients, it's really important for us as the nurse to assess an older adult's functional status. So especially looking at their ability to perform those activities of daily living, like walking, getting dressed, eating their food. And so understanding these normal aging changes helps us to identify when a neurological change is abnormal and can indicate a disorder that requires further evaluation. So an important part of neurological health is prevention, of course, and we always talk about prevention. And as nurses, we play a key role in teaching patients how to protect their nervous systems. So as we've discussed, the nervous system is very important in maintaining just our functional ability. And so we want to make sure that we're protecting it. So a lot of neurological disorders are linked to risky behaviors like substance abuse, head injuries, not wearing seatbelts or helmets, chronic stress, not getting enough sleep. So encouraging patients to avoid these risks is a major component of health promotion. Getting enough sleep is really important because when we sleep, the brain processes information, it repairs itself, and helps maintain cognitive function. Proper nutrition is also really important because it supports brain health, especially diets that are rich in like omega-3 fatty acids, antioxidants, and adequate vitamins. All of these things help to support nerve function and slow that cognitive decline. A healthy lifestyle that includes regular physical activity, stress management, avoiding smoking, and also avoiding excessive alcohol use. All of these things can significantly reduce the risk of neurological conditions like stroke or dementia. So, an important part of neurological health is prevention, as we talked about. And so, did I not switch the slide? There we go. Okay, let's talk about posturing. Decorticate posturing and decerebrate posturing. Those are the two things that are pictured here. So the first one, A, that's decorticate posturing, and then B is the decerebrate posturing. So posturing refers to abnormal body movements that occur when there is severe damage to the brain, and it also helps us to identify the level of injury to the brain. Decorticate posturing, which you see in image A, and that is spelled DECORTICATE. So that's characterized by the arms being flexed and pulled out or pulled upwards towards the core of the body, with the wrists and the fingers flexed and the legs extended. So that type of posturing usually indicates damage to the areas above the brainstem, like the cerebral hemispheres. And then more seriously, image B, that's called decerebrate posturing. That's spelled DECEREBRATE. So that's more serious. It's characterized by the arms extending and rotating outwards with the wrists flexed and like the legs extended and kind of rigid, like you can see in this picture. So decerebrate posturing actually suggests damage to the brainstem, which, as we discussed, is really essential for controlling those vital life functions like breathing and heart rate. So because that decerebrate posturing indicates a lower and more severe level of brain injury, it's considered a worse sign than decorticate, as you see in A. So it's important to recognize that the postures, when you're doing a neurological assessment, it helps us respond quickly, and also notify the provider of potential neurologic deterioration. This is our Glasgow Coma Scale. You'll also hear it referred to as GCS. It's a pretty standardized tool that you'll see used very often in the hospital setting. It assesses a patient's level of consciousness after a head injury or during neurological evaluations. So it evaluates three main areas: the eye-opening response, the verbal response, and also their motor response. So each category, it's scored individually and then added together to get a total score ranging from 3 to 15. So a score of 15, that indicates like a fully alert, oriented patient. And then a score of 8 or below, that suggests the patient is like in a coma and is probably going to need airway protection. So one way that I really was able to remember this, it's a good little motto to remember, but it's the saying like less than 8 we intubate. So if their Glasgow Coma Scale is 8 or less, we're going to be prepared to need to protect that patient's airway. The motor response section, so that part's especially important because it reflects the brain function and can show abnormal posturing, such as that like decorticate or decerebrate posturing that we looked at. So the Glasgow Coma Scale, it really allows us to track changes over time. So that's why this scale is so important. So whenever you have a patient come in, they've had a brain injury, one of the first things we want to do is get that baseline Glasgow Coma Scale to see where they're at. Because if we start to notice that our patient is having a decline or showing some neurological changes, we want to then do another Glasgow Coma Scale to see if their number is decreasing. Because if it is, then that's a sign that neurologically their condition is worsening, and we definitely need to be aware of that. So of course, we need to consider the psychosocial assessment. It's important not to overlook that aspect, because these neurological conditions really can often affect a patient's mood, behavior, and emotional well-being. So a patient's response it could differ depending on whether their condition is acute, like a stroke or a head injury, or if their neurological condition is chronic, like with Parkinson's disease or multiple sclerosis. So patients with acute conditions, of course, will probably be experiencing fear, anxiety, confusion due to the sudden changes, while those with chronic conditions will probably be struggling with things like frustration, social withdrawal, or long-term coping challenges. Depression is especially common among patients with neurological disorders, which is why using a depression screening tool, a common one is the PHQ-9, can be appropriate as part of that assessment. So we need to really observe changes in their affect, their facial expressions, eye contact, social interaction, and also just assessing their motivation, like on a day-to-day basis if they're possibly feeling depressed. So we want to make sure we're identifying those psychosocial concerns. As we're looking at neurological care, there's laboratory testing and imaging studies that we can do to help us identify and diagnose these nervous system disorders. So our lab assessments can include tests like our CBC, electrolytes, coagulation studies, and glucose levels. All of these can detect things like infection, bleeding risk, or metabolic imbalances that are affecting the brain function. Imaging studies are also really important for visualizing the brain and the spinal cord. And then x-rays, like doing an x-ray, can help to detect a skull or spinal fracture. Cerebral angiography or arteriography, that shows how the blood is flowing in the brain's vessels, and it can detect like an aneurysm or even like a blockage, which can lead to a stroke. And then the CT scan, that's usually our hallmark. It's usually the first imaging that we do with a patient that is experiencing a stroke or has experienced trauma. It can be done with or without contrast. It's done quickly and it just gives us a good quick look at that brain. But then the MRI, that provides really more detailed images of the soft tissue. It's useful for diagnosing things like tumors, multiple sclerosis, spinal issues. PET scans, so those assess brain metabolism and function, while the SPECT, the single photon emission CT, that evaluates blood flow as well and can also detect areas of decreased perfusion. The MEG measures electrical currents in the brain and is sometimes also used to locate seizure activity, although the EEG is more of the hallmark test for that. And we'll talk about that on the next slide. And so as the nurse, we really need to think ahead and prepare for what our patient could possibly be needing if they come in with a neurological injury, and what we need to do as the nurse to prepare them for that. So for example, if we have a patient with a CT scan with contrast ordered, we've talked about this, but of course, first we want to check for allergies, specifically iodine or shellfish, which could indicate that they have a sensitivity to the contrast dye that they're going to use in that CT scan. We need to ensure that they have a good patent IV line. It has to usually at least be a 20 gauge in the antecubital or the forearm to use those larger veins to allow for the rapid contrast injection. Of course, also if a patient is doing a CT with contrast, we want to check their kidney function using the BUN and creatinine levels because that contrast dye can be hard on the kidneys. Hydration is also important. Usually after a CT scan, they'll get some IV fluids just to help flush that contrast out. So just anticipating these kinds of things, we want to think about what is our patient going to need and what do I need to do as the nurse to prepare them for that. So electromyography or EMG, that's a diagnostic test that's used to evaluate muscle and nerve function by measuring the electrical activity of skeletal muscles. So it helps to identify conditions like peripheral neuropathy, myasthenia gravis, or muscular dystrophy. During an EMG, small needle electrodes are inserted into the muscle, so the patient feels some mild discomfort or twitching. And it's important for nurses to educate the patient about what to expect, just to make sure that they avoid putting on any like lotions or creams beforehand, because that can interfere with the test. And then we talked on the last slide about EEG. That's usually our hallmark for recording that electrical activity in the cerebral hemispheres. It's commonly used to diagnose neurological disorders like seizures, epilepsy, sleep disorders, or brain activity in coma patients. The test uses electrodes that are like attached to the scalp in certain spots, and the patient has to remain still and relaxed to get accurate readings. So those are some things to consider about educating our patients about those tests. A lumbar puncture, so that is also known, you've probably also heard it called like a spinal tap. It's a procedure used to collect cerebral spinal fluid, also called CSF, for diagnostic testing. Sometimes it's also done to relieve pressure around the brain and spinal cord. If that cerebral spinal fluid, if there's too much of it, it can remove some of it and take some of that pressure off of the spinal cord. So the patient, you can see in this picture, they are positioned in a flex position where they're lying on their side with knees drawn up to the chest. That flex posture maximizes that space between the vertebrae, allowing easier and safer needle insertion. This is done by a physician, but as the nurse, you'll be there to assist to help position the patient and keep them in that position during the procedure. So the lumbar puncture needle is typically inserted between the L4 and the L5 vertebrae, which allows the physician to gain access to that subarachnoid space where the cerebral spinal fluid circulates. So the reason they choose that L4 and L5 vertebrae is because it is below the end of the spinal cord, so it helps prevent nerve injury. So during the actual procedure, the patient would be gowned and draped, of course, to protect their privacy, but in this image, they're not, so that you can get an idea of how they would be positioned.
Do they use any kind of anesthetic for that?
They do use an anesthetic, yeah, they numb the area before they insert the needle. So really, that's usually the most uncomfortable part for the patient is the numbing medication, and then afterwards, they'll just feel some pressure and like a pop when they enter that space. So after a lumbar puncture, our nursing care, it's really focused on monitoring for complications and promoting patient comfort and recovery. The most common complication after a lumbar puncture is what's known as a post-lumbar puncture headache. It typically worsens when the patient sits or stands, and it improves when they're lying flat. To reduce the risk of that, patients are usually instructed to lie flat for several hours after the procedure, depending on the facility policy. We also really want to encourage adequate fluid intake because it helps replace that cerebrospinal fluid that was removed for the procedure and can decrease that headache severity. We also want to monitor the puncture site for any signs of CSF leakage or bleeding or infection. Of course, our signs of infection, we're looking for like that redness, swelling, drainage. We also want to assess their neuro status regularly, including their level of consciousness, their motor strength, their sensation, their vital signs. And we want to tell the patient that if they start to experience any symptoms of like numbness, tingling, difficulty moving their legs, we definitely want them to let us know. That can indicate that a nerve was possibly irritated or affected during the procedure. And then if that severe headache persists, if they're having that severe post-lumbar headache, the provider can do something that's called a blood patch to seal the leak. They literally I've seen it done a few times before. They use the patient's blood. They go in, they seal the leak at the insertion site, and that can help with that headache. But that's in more severe cases when it's not being managed with other interventions.
If they have the lumbar puncture because they have they're suspecting meningitis, so they started out with a headache, how do they differentiate between the two? Like if it's a complication from the puncture or
so in that case, if they already had a headache, like if they have meningitis, so the question was if the patient already has a headache because of something like meningitis, how do they differentiate between like a meningitis headache versus a headache related to the lumbar puncture? In that case, honestly, you really can't, because the symptoms are the same, and so we would just treat the headache and continue to monitor the patient. it's hard to kind
keep a
of
close eye on them.
differentiate the two,
Okay.
yeah. I mean, one way is if the headache gets better when the patient lays down flat, then we can know it's more related to the lumbar puncture.
Okay.
But that's really our only like differentiating ability for
Okay.
that. So the nurse is caring for an older adult who is usually alert and oriented. When the patient exhibits a change in mental status, sorry, I feel like this could have been worded better. So when the patient exhibits a change in their mental status, which cause does the nurse usually assess? Especially think about our elderly patients here. A with infection. So with those older adults who are typically like alert and oriented, a sudden change in mental status like confusion or disorientation, that's a red flag. Okay. I'll leave you with that meme there. Let's take just a little break while I pull up our next PowerPoint. Come back at 10:10. Okay, let's get started on our nervous system problems here. So, for this chapter, we're going to focus on a lot of different neurological conditions and how we take care of those conditions as the nurse. We'll talk about migraine headaches, Parkinson's, Alzheimer's. So let's dig in here. So Alzheimer's disease, that's the most common form of dementia, but it's important to really emphasize and understand that it's not a normal part of aging. So we kind of talked about in the previous chapter how some cognitive changes are normal as our patients are aging, like slower cognitive processing, mild confusion. This is on a different level and it's not a normal part of aging. So in Alzheimer's, there's marked atrophy or shrinking of that cerebral cortex, which is the area of the brain responsible for the higher level functioning that we talked about, like memory, language, judgment, and decision making. So you can see how as that cerebral cortex is shrinking, why we see those symptoms in patients with Alzheimer's. So when that area degenerates, the patient gradually loses their ability to process information, recall memories, and communicate effectively. So microscopic changes in the brain that we see with Alzheimer's include neuritic plaques, which are abnormal clusters of protein fragments that disrupt that neuron communication. We see vascular change or degeneration, so changes in the blood flow. It reduces the blood flow and contributes to cell death in the brain. There are also neurotransmitter abnormalities, especially a decrease in certain enzymes that are necessary for producing acetylcholine. So acetylcholine is a key neurotransmitter involved in cognition and memory. And so over time, these structural and chemical changes progressively impair all of the major communication, as well as the patient's ability to process their brain function. So when we're assessing a patient with Alzheimer's disease, it's important to understand that age is the greatest risk factor. The likelihood increases significantly after the age of 65. Gender can also play a role. Women are more affected than men usually. And then genetics is another factor. So certain genes are linked to an increased risk. Unfortunately, there's currently no proven ways to prevent Alzheimer's disease. And during the physical assessment, nurses, they really gather a thorough history that includes the family background, symptom onset, and progression of memory or behavior changes. So Alzheimer's, it's classified into different stages. There's early, middle, and late, and these are classified based on the severity of cognitive and functional decline. So as the disease progresses, patients experience changes in cognition, behavior, as well as their personality and their self-management skills. And unfortunately, they usually lose the ability to perform those activities of daily living. So this image kind of shows a lot of several key terms that are used to describe common symptoms in Alzheimer's disease. So apraxia, that refers to the inability to perform purposeful movements or use objects correctly, even though the physical ability is intact. Aphasia is the loss of the ability to understand or express speech. Anomia describes difficulty remembering the names of familiar people or objects. Agnosia is the ability or the inability to recognize objects or even people through sensory input, even though the senses are functioning. And then amnesia refers to memory loss, which is typically one of the earliest and most recognizable signs of Alzheimer's disease. So the number one priority in caring for a patient with Alzheimer's disease is, of course, their safety. Because these patients usually experience confusion poor judgment and memory loss, they're at a higher risk for falls, wandering off, injury. So as the nurse, our goal is really to manage memory and cognitive dysfunction while also maintaining their dignity and independence as much as we possibly can. The non-pharmacological interventions, those are usually the most effective interventions early on. So those include maintaining like structured daily routine that's predictable for them, using calendars or visual cues to aid their memory, and then also just providing them with meaningful activities like music, art, gentle exercise, things to keep them busy and to keep their brain working as much as possible. And then when you're helping them with activities of daily living, we really want to promote that independence as much as possible by giving them like step-by-step instructions and then allowing them plenty of time to complete those tasks. So there is some drug therapy that we can include. Highlight this in your notes, it's important to know. So there are some medications that can slow the cognitive decline. It doesn't cure Alzheimer's disease, but one of those medications is called Aricept. So donepezil, Aricept is the brand name, but
Can you spell that?
yes, Aricept, it's spelled ARICEPT. So that helps to slow the decline, but it doesn't cure the disease. And the earlier we can start it, the better. So there are safety measures that a caregiver can implement in the home, like alarms on doors, non-slip footwear, adequate lighting. All of those can prevent injuries or accidents, especially as the disease progresses. And then when the patient's needs exceed what can safely be managed at home, placement in a long-term care facility may become necessary. And as nurses, we really play a key role in supporting the family through that transition because it can be a really difficult transition. With these patients, we really want to avoid restraints because it can increase their agitation, confusion, and their risk of injury. Instead, consider using other alternatives like frequent observation, bed alarms, distraction techniques, or a calm environment to help maintain safety without compromising their dignity. So some really good distraction techniques that are easy to do. I like to give my patients washcloths that are just like clean and ask them if they're willing to fold them for me. That seems to be a good distractor for them that keeps their hands busy and they feel like they're doing something. Also, some patients really like, I know I used to work on a unit that kept like a baby doll, and we could just give the baby doll to the patient wrapped in a blanket and they felt like they were taking care of the baby. So using those distraction techniques really helps to keep them calm. When you're caring for someone with Alzheimer's, communication is paramount. So you always need to be calm, simple, reassuring. Use short sentences. Maintain the eye contact with them. Call the person by their name. In the early stages of Alzheimer's, we focus more on memory support and independence. In the middle stage, we really need to kind of simplify that communication and assist them more with their activities of daily living. And then in the late stage of Alzheimer's, we focus more on like comfort, skincare, and maintaining their nutrition as much as possible. So caring for a person with Alzheimer's disease, it really extends far beyond the hospital. It definitely requires coordination across multiple settings and strong support for both the patient and the caregiver or caregivers of the patient. Home care management really focuses on creating that safe and structured environment, reducing the clutter, labeling important items for the patient, and also removing hazards to prevent falls and prevent the patient from wandering away. Respite care also provides temporary relief for caregivers. So the caregivers really face a lot of strain because they are watching someone 24/7. So allowing other family members, or you can also hire like other professionals or volunteers to come in and care for the patient for even just short periods, which is really vital to prevent that caregiver burnout, just to give them a short break. So These caregivers, they usually experience a lot of exhaustion, stress, depression, so connecting them with support groups is also important. And they also need to be taking care of themselves so that they are not pouring from an empty cup. We also need to connect these families with resources like social workers, Alzheimer's associations, community day programs that can offer support and education. There is also a program called the Safe Return Program. It's a really good resource that helps locate patients who or family members with Alzheimer's who have wandered off and become lost. So this program, it gives them an identification bracelet and it registers them with the local authorities so that if they do wander off, they can be located again. And again, that's called the Safe Return Program.
Is that like a nationwide thing?
It's nationwide, yeah. Yeah. Okay, so let's move on to talking about Parkinson's disease here. So Parkinson's disease, this is a progressive neurodegenerative disorder that affects movement and coordination. So it develops gradually as neurons in the brain degenerate. So the neurons specifically related to this, they produce dopamine, which is a neurotransmitter responsible for smooth, controlled muscle movement. So as these dopamine levels in patients with Parkinson's disease, as they decrease, there is an imbalance between dopamine and acetylcholine. So that leads to movement difficulties that we see in these Parkinson's patients. So the result of this is we see the development of 4 cardinal symptoms that we see in patients with Parkinson's disease. So a tremor, muscle rigidity, bradykinesia. So bradykinesia means like slow movements, and then also postural instability. So they just have difficulty maintaining their balance. The symptoms can start on one side of the body and progress to both sides of the body as the disease advances. And then over time, patients can also experience changes in facial expression, speech, swallowing, and their gait. So they develop a really characteristic like shuffling walk that you'll commonly see in patients with Parkinson's disease. And then Parkinson's progresses through different stages. So stage 1 is mild and just can include like subtle tremors, and then it can advance all the way to stage 5 where the patient is completely dependent on other people to care for them. In terms of managing the disease, care is really focused on balancing that dopamine and acetylcholine using medications like levodopa, carbidopa. You'll see that one prescribed commonly. We'll get to that when we're talking more about the treatment here. So when you're performing a physical assessment on a patient with Parkinson's disease, we really focus on the classic motor symptoms and the functional changes that result from them. So rigidity, that's one of those 4 cardinal symptoms, and it can be assessed by moving the patient's arm or leg, either through passive or active range of motion. So either like you're helping the patient move or the patient independently moves. And you'll feel a resistance described as cogwheel rigidity. And so that's like a jerky rhythmic pattern as the patient is like trying to extend with that range of motion. So it feels like a steady resistance throughout the movement. Their facial expression also often becomes mask-like with decreased blinking and limited emotional expression, which can make communication difficult for them. You'll also notice emotional changes like depression or flat affect due to both the disease process and also that neurotransmitter imbalance. We do see bowel and bladder changes as a common symptom as well, including constipation and urinary urgency or incontinence, because the autonomic nervous system is affected by Parkinson's disease. And then our laboratory and imaging assessments are mainly used to rule out other conditions. So there isn't a specific diagnostic test that we do for this. Diagnosis is just based primarily on assessing those clinical symptoms that we talked about. So So when we're really considering the pathophysiology here, think about what happens when dopamine is depleted and that acetylcholine becomes more unopposed. So like we talked about, that dopamine, it normally really helps with smooth, coordinated movement, while that acetylcholine stimulates that muscle activity. So without the dopamine there to like balance things out, that acetylcholine is going to cause that excessive like muscle contraction, leading to those tremors, rigidity, really slowed movements. So that's how we can think about that. Here is an example of that hallmark mask-like facial expression that we'll see in Parkinson's disease due to those lower dopamine levels. So that face can really appear like stiff and expressionless, not as much blinking, minimal emotional display. So promoting mobility when we're looking at how do we manage Parkinson's disease. Promoting mobility is one of the most important nursing priorities for patients with this disease. So because these patients experience that bradykinesia, like that slowed movement, rigidity, issues with their gait, exercise programs and physical therapy play a really important role in maintaining that strength, flexibility, and balance. So we really want to encourage activities like walking, swimming, stretching. We want to remind those patients to move slowly and deliberately to prevent falls. Physical therapists can also teach them specific techniques, like the rocking side to side before standing, or using like a wide base stance to maintain their stability. Drug therapy is another essential part of treatment. So we talked about that levodopa carbidopa. The brand name for that is Sinemet, Sinemet. So those dopamine agonists, they mimic the effects of dopamine in the brain, and they can be used early on in the disease to reduce those symptoms. So timing with those is really critical. If you're a nurse taking care of a patient that is taking that medication, you want to make sure you're administering it at the same time each day to maintain that consistent symptom control. Another thing to consider with the levodopa carbidopa, the Sinemet, so meals that are high in protein can interfere with absorption of that medication. So we want to educate our patients on medication timing. They don't necessarily want to take that medication with a high protein meal. In some cases of Parkinson's disease, surgical management like deep brain stimulation can be used to help control severe tremors and rigidity when the medications are no longer effective. And then beyond physical symptoms, it's just really important to promote self-esteem for these patients. Parkinson's disease can cause a lot of frustration, embarrassment, and social withdrawal due to the tremors and the speech changes and the mask-like facial expression. So we really want to encourage our patients to join support groups, provide them with some emotional reassurance, and do the best we can to help them adapt their environment to manage their disease process. Okay, so let's talk about migraines. So a migraine, these are recurrent episodic attacks. They can range from moderate to severe in intensity, and they're often accompanied by symptoms like nausea, vomiting, sensitivity to light, sound, head movement. So migraines are caused by abnormal changes in blood flow and nerve activity in the brain, and that triggers inflammation and pain pathways. So patients, this is important to remember, one of the first signs they'll see before migraine starts is what we call an aura. So they'll have like visual disturbances, tingling sensations. Some people describe seeing like the visual disturbances as just seeing like little spots that are just like black in their vision, that they're having these visual disturbances. So that usually happens before the headache begins. They won't have an aura every time, but that's usually how they know. It's a common way that they know that like a migraine is coming on. So we really want to educate patients on identifying and avoiding their own individual triggers for migraines. So prevention is a really important part of migraine management. A lot of common triggers for migraines are things like caffeine, red wine, chocolate, aged cheese, foods containing a lot of MSG or nitrates. Some other triggers for migraines can include things like stress, lack of sleep, hormonal changes, skipping a meal, even like really strong odors. So by helping patients understand what triggers that migraine for them, we can help them avoid a migraine, hopefully. So when we're assessing a patient with migraine headaches, it's really important to start with a detailed history. We want the patient to identify the pattern of the headache, the duration, the characteristics of the pain. We want to ask them when the headache began and how often they usually get migraine headaches. And when they do get them, we want to ask them what they feel like and whether anything seems to trigger or relieve them. Again, we want to ask them about that aura. It usually develops gradually over several minutes and serves as that really early warning sign. And then during the headache phase, patients will usually report that loss of appetite, nausea, vomiting, photophobia, a lot of sensitivity to light and sound. And those symptoms can even be so severe that patients have to rest in a dark, quiet room. So as a nurse, if you have a patient that comes in and we're treating them for a migraine, we want to make sure that the room is dark and quiet and that we're minimizing how many times we are needing to go in and out of that room. So we just want to allow that brain to rest as much as possible. So while all migraines are headaches, not all headaches are migraines, if that makes sense. So headache, that we want to be able to differentiate between if a patient is experiencing a headache or if they're experiencing a migraine. So a headache is really a general term for pain or discomfort in the head, scalp, or neck. It can be caused by stress, muscle tension, sinus congestion, dehydration, or even straining your eyes, like if you've been studying for an exam for a long time and staring at your computer screen. They're usually described as a dull, steady pressure or tightness and often relieved by like rest, hydration, over-the-counter medications. Now, in contrast, a migraine is a specific type of headache disorder. So, like we mentioned, it involves those changes in the blood flow and the nerve signaling within the brain. So, migraines usually cause severe, throbbing, pulsating pain. It's usually unilateral, so it's often on like one side of the head. That's important to know. It's also important to know, again, that we see those additional symptoms like nausea, vomiting, the sensitivity to light and sound, and sometimes that aura that precedes the headache. Migraines can really last for hours or even days and can significantly interfere with the patient's daily activities. So when we're taking care of these patients with migraines, like I mentioned, it's important to keep them in like a dark room with minimal noise where we are entering and leaving the room as little as possible. The top priority of care for these patients is pain management. So these migraines can be really debilitating, and our goal is to relieve those symptoms as quickly as possible, and also prevent future attacks. So when we look at drug therapy for migraines, it's divided into two categories. So abortive and preventive. Abortive is like the treatment. So abortive therapies are taken at the onset of the migraine. The earlier, the better. And it stops or reduces the pain. So some common examples include NSAIDs like ibuprofen, Motrin, Excedrin. So it can help with mild to moderate headaches. For more severe migraines, we can give triptans, like Imitrex is a common medication, so that helps to constrict those blood vessels and block pain pathways in the brain. So it's important to teach patients to take these medications as soon as the symptoms begin for the best results. Some of our preventive therapies will resort to these when migraines occur really frequently or severely, and it severely affects their daily life. So some of those medications include beta blockers like your propranolol, calcium channel blockers, anti-epileptic medications like topiramate. So those medications can help reduce the frequency and intensity of those migraine attacks over time. So we really want to emphasize with our patients that experience migraines, they want to take those preventative medications consistently, even when they're not experiencing pain. And again, we talked about the importance of avoiding their known triggers for what can cause those migraine headaches. So let's kind of go through a case study here for a patient with Alzheimer's. So the wife of a patient recently diagnosed with Alzheimer's disease asks the nurse if there is a cure for her husband's illness. What is the nurse's best response? So raise your hand if you think it's A. B. C. D. Okay, glad I saw most of the hands on B. So that medication Aricept can slow the progression of the disease. So the wife states that her husband is able to perform most of his own activities of daily living and wants to keep her husband safely and independently functioning in their home as long as possible. To help her husband maintain safe independence, which action should the nurse recommend? Okay. So this one, raise your hand if you think it's A, B, C, or D. You guys are so smart. Good job. So we want to place outfits on hangers that allow the patient to choose what to wear. We talked about the importance of having those consistency in the routine. The predictability really helps with patients with Alzheimer's. So at a 6-month follow-up appointment, the wife states that the patient occasionally has difficulty finding the correct words to use when he is communicating. What term does the nurse use to document this assessment data? So that is going to be C, our anomia. So anomia is the inability to recall the names of familiar objects, people, or places. So even though they recognize what they are trying to describe, they are not able to. It's a common early sign of Alzheimer's disease, and it can be really frustrating for the patient.
What's the difference between anomia and aphasia?
Aphasia is more of a functional like difficulty with speaking,
Okay.
whereas anomia is more of like the difficulty to like
Recognize.
recall it.
Okay.
Yeah. Okay. This one is a select all that apply. So the patient's wife calls the physician's office to report that she is concerned because the last time her husband took a walk in the neighborhood where they all lived for 35 years, he got lost and a neighbor brought him back home. What measures should the nurse recommend for patient safety? Select all that apply. So this one is about our safe return program. So we want to enroll him in that safe return program. They will send an ID that he can wear. It also connects him to where he lives. It notifies the local authorities of who he is and what his condition is. And so that allows him to stay safe in the event that he were to wander off. And this one isn't related to the case study. This one's about Parkinson's disease. But when caring for a patient with Parkinson's disease, the nurse understands that progressive difficulty with which factor is a primary expected outcome. So raise your hand if you think it's A, B, C, or D. Good job. So motor ability. So when we're caring for a patient with Parkinson's disease, the most significant progressive difficulty occurs with their motor ability.
Back to slide 20, I think I missed that one.
Slide 20. Oh, I took a question out.
Did you? Okay.
Yeah, sorry. There might be an extra question that I took out. Okay, so let's talk about back pain. Back pain, that's one of the most common musculoskeletal problems that nurses will encounter. You'll see this very often with patients. And so understanding its cause and underlying pathophysiology, that's essential for effectively assessing our patient and educating them on how to prevent it. There are a lot of potential causes of back pain, including obesity, which places extra stress on those spinal structures, injury or trauma, certain occupations or hobbies that require a lot of repetitive, like bending, lifting, twisting, osteoporosis. So you guys remember that from your previous musculoskeletal chapter, but that weakens those bones and increases the risk of vertebral fractures. Poor posture can also affect back pain because it puts a lot of strain on those muscles and ligaments over time. So with back pain, we classify it as either being acute or chronic. So acute pain, that usually will develop suddenly after an injury or a strain, and it will last less than 6 weeks. While chronic pain will persist for more than 3 months, and it can be related to degenerative changes or nerve involvement. So the pathophysiology behind back pain, it can vary depending on the cause. So common causes include muscle strains or spasms, which occur when supporting muscles are like overstretched or overworked. Arthritis of the spine, especially the osteoarthritis, leads to inflammation and joint stiffness. Disc herniation occurs when the soft center of one of those intervertebral discs like pushes through its outer layer. And when it does that, it presses on spinal nerves and causes like a radiating pain or numbness. Spinal stenosis, that is the narrowing of the spinal canal, usually due to aging or degenerative changes, and it compresses the spinal cord or the nerve roots. And then finally, repetitive motions, usually related to work or other. So if it involves a lot of like twisting or lifting, it can gradually wear down the spinal structures and lead to that chronic pain and decreased mobility. So when we're assessing a patient with back pain, we really want to focus on the subjective symptoms, like what the patient describes, as well as objective findings. So a lot of patients describe the back as being like painful and stiff with a really limited range of motion, especially when they're bending or twisting. You may observe that the patient has kind of an awkward gait or stance as they try to avoid like certain movements that can worsen their back pain. So that can really provide a lot of important clues to us about if they're having like muscle spasms or nerve involvement. It's also common for patients to report tingling or numbness, which can occur either on one side or both sides. That can indicate nerve compression. One of the common nerves that we see compressed that contributes to back pain is the sciatic nerve. The patient will describe that as a pain that like shoots down one of their legs. Assessing function is also critical, so asking them about any changes in mobility, balance, or coordination, since that can suggest that there's some kind of spinal cord involvement. Bowel and bladder function should always be evaluated because loss of control of either of those can indicate medical emergencies like requiring immediate intervention. And then some of our imaging studies that we can do, like x-rays, MRIs, or CT scans, those can be ordered to identify any structural problems that we could see, like fractures, herniated discs, any spinal degeneration that could be taking place there. So some of our interventions, back pain is usually managed with non-surgical interventions. They're usually aimed at like relieving discomfort and improving mobility and also preventing further injury as well. So some common comfort measures include heat therapy to relax tight muscles. Massage helps to increase blood flow, and the use of topical creams or patches also provides some more localized relief. Proper positioning is really important for pain control, and important thing to take note of. So one of the most effective positions that we can educate our patient about is the Williams position, to help relieve back pain. So in that position, the patient lies in like a semi-Fowler's position or flat if they can tolerate it, but usually semi-Fowler's, with the head of the bed elevated at about 45 degrees, and then the knees are flexed, usually by putting a pillow underneath them. So that alignment reduces pressure on the lumbar spine by relaxing those hip flexors and the back muscles, and it helps to relieve that back pain. So placing a pillow under their knees or even like lying in a recliner with their legs supported is one of the most comfortable ways for them to get some lower back pain relief. So some other non-surgical strategies include NSAIDs like ibuprofen to decrease inflammation, gentle stretching and physical therapy, losing weight to help reduce stress on the spine. A TENS unit, so that's a transcutaneous electrical nerve stimulator. It comes like they put patches in certain spots on the back, and it delivers these like mild electrical impulses. It helps to block those pain signals and helps the muscles to relax. Now, when some of these more conservative non-surgical treatments are not effective, surgical management may be necessary. So some common procedures that we'll see are like a spinal fusion to relieve pressure on those nerves or to stabilize the spine. One of the outpatient procedures that you can see is they'll do a steroid injection. If there's like a herniated disc, it allows that to relax and slip back into place. So there are some surgical interventions that we can do as well. So a bulging or a herniated disc, this occurs when as we kind of look more at the cervical area, which is up here, like in the neck. So that occurs when that intervertebral disc, it pushes through its outer cartilage layer. So it compresses like a nearby spinal nerve. That compression causes a lot of pain, numbness, tingling, or weakness in the area that is served by that nerve. So it will usually radiate down one leg, which we call sciatica. We talked about that. It can result from like poor posture, aging, osteoarthritis, rheumatoid arthritis, inflammation or infection in the spine that can also weaken the discs and contribute to herniation. Over time, repetitive movements, again, that can really further damage the spinal structures and lead to herniations. And then our interventions, again, a lot of that physical therapy, stretching, NSAIDs to control inflammation. I'm gonna skip past this one, but because I want us to look at one more thing before we're done for the day. But the correct answer is A, B, C, and D. So those 4 items: losing weight, avoiding twisting at your waist, exercising on a regular basis, and not bending at your waist when you're lifting a heavy object. All of those help prevent lower back pain. Okay, so let's talk about Guillain-Barré syndrome, or GBS. So Guillain-Barré, this is an acute autoimmune disorder. The body's immune system attacks the myelin sheath that covers those peripheral nerves. So the myelin sheath, again, to kind of review some of this patho, that is what covers those nerves, and it's really essential for like that rapid nerve conduction. So when that myelin sheath becomes damaged, the nerve signals slow down or stop completely. So that can lead to weakness, numbness, even paralysis. So Guillain-Barré syndrome, it begins after a viral or bacterial infections that triggers that immune response. It can also be triggered by certain immunizations. So that causes antibodies to mistakenly target the body's own nerves. A classic feature and something important to remember about Guillain-Barré syndrome is that it starts in the distal nerve, so it will usually start in like the feet and the legs, and then it progresses upwards towards the trunk and the arms. So that pattern, we call that ascending paralysis, and that is a hallmark sign of Guillain-Barré syndrome. So as the disease progresses, this is what makes it so dangerous, is it progresses up into the trunk and it can really affect those respiratory muscles and the cranial nerves. So we want to really closely monitor those patients. So GBS, it usually develops in 3 stages. The acute stage, that is when symptoms are rapidly worsening and that demyelinations, like the breakdown of that myelin sheath, is actively occurring. During the plateau stage, symptoms have stabilized, but they have not yet improved. And then during the recovery stage, the remyelination begins. So the good news is that the nerves can remyelinate, the nerve function can return. So recovery can take a long time. Patients who have Guillain-Barré syndrome are usually hospitalized for quite a while and then need to continue physical therapy for months and even years afterwards, just kind of depending on the extent of that nerve damage. So this image here, it really helps us to visualize what happens in Guillain-Barré syndrome. Again, it's an autoimmune disorder, so it affects the peripheral nervous system. So that is the nerves that connect the brain and the spinal cord to the rest of the body. So the diagram on the left, that shows how Guillain-Barré syndrome involves the nerves that extend from the spinal cord, not the brain or the spinal cord itself. So the immune system mistakenly attacks that myelin sheath. And then on the right side of the image, you can see the difference between a normal nerve where the myelin sheath is like intact and smooth. And then underneath that, there's an effective nerve where the myelin sheath is damaged by that autoimmune process. So as those nerve signals become disrupted, those patients begin to experience the ascending paralysis, the weakness, numbness, tingling that starts in their feet and moves upwards. And then if that demyelination reaches the chest, that's where it can start to affect their respiratory muscles, creating a risk for respiratory failure. So that is why maintaining their airway is a huge nursing priority for patients who are experiencing Guillain-Barré syndrome. But again, the good news is that in the recovery stage, that myelin sheath can regenerate and allow that nerve function to return over time. So it doesn't destroy the nerves themselves, it just damages the insulation on the nerves, which is why with supportive care, those patients can recover most or all of their function. So when we're assessing a patient with suspected Guillain-Barré syndrome, a detailed history is really important. Symptoms usually begin a few days to weeks after a viral or bacterial infection, like a respiratory or a gastrointestinal illness. Those early signs include weakness, difficulty walking, which progresses upward from the lower extremities to the upper extremities. So some patients report tingling or numbness in their hands and feet. And because it affects both sensory and motor nerves, they can also notice like changes in their blood pressure or an irregular heart rate, especially when the autonomic nervous system becomes involved. They can also report some double vision, difficulty swallowing, or facial weakness that can occur when the cranial nerves become effective. So a full cranial nerve assessment is an important part of the neurological exam. And as I say cranial nerves, that reminds me to tell you that you will see the hard work that you put into preparing for your holistic assessment exam to memorize the cranial nerves and what they do and which nerves affect which part of the bodies. You will see that again sometime. So just make sure you review that just in general. Okay. So for diagnosis, several tests are used to confirm Guillain-Barré syndrome and also rule out other conditions. So we can do a lumbar puncture. We talked about those. They can be performed to analyze that cerebrospinal fluid. A hallmark finding in a patient with Guillain-Barré syndrome, when we look at that cerebrospinal fluid, is elevated protein levels with a normal white blood cell count. So that reflects nerve inflammation without infection. So that's us ruling out other disease processes here. A CBC, a complete blood count, can be ordered to identify signs of infection or inflammation. Nerve conduction studies also help assess how quickly the electrical signals are moving through the nerves. So a delayed conduction confirms that demyelination of the nerve. This image here, it just shows us a good summary of the Guillain-Barré syndrome. It's good to look at as you're studying for your exam. So just looking at how the condition progresses, again, the ascending paralysis, that is a hallmark sign that we'll see. As you can notice here, it's usually preceded by a mild respiratory or intestinal infection, usually viral, but sometimes bacterial. And it can also occur after immunizations or other immune triggers. So anything that's triggering that immune system. All right. So when we're caring for a patient with Guillain-Barré syndrome, the highest priority is maintaining that respiratory and cardiac function. Because the paralysis moves upward, it can eventually affect the diaphragm and the intercostal muscles, which makes breathing really difficult or impossible. So the nurses need to really closely monitor their respiratory rate, depth, oxygen saturation, and also their vital signs. So we need to note any signs, early signs of respiratory failure. Continuous cardiac monitoring is also necessary because that autonomic nervous system can be affected and it can cause those blood pressure fluctuations, bradycardia or tachycardia. And then early recognitions of those changes can really save someone's life. So we're keeping a very close eye on these patients. The medication treatment for Guillain-Barré syndrome is called IVIG. So that stands for intravenous immune globulin, and you'll heard it referred to as IVIG. It's used to reduce circulating antibodies and shorten the course of the disease. It's also a very expensive medication. That's just a interesting thing to note. So just know when you're hanging a bag of IVIG on your patient that bag of medication is roughly $20,000. And so you want to take very good care of it and make sure you are doing it correctly. So bring a buddy. Aspiration precautions are essential with these patients, especially if cranial nerves controlling the swallowing are affected. So we want to keep suction nearby, elevate the head of the bed. We're going to work with like speech therapy to do swallowing evaluations. We want to do ongoing neurological assessments to track any progression of the weakness, tracking their reflexes, any sensory changes. Because the immobility caused by this can last for weeks, physical and occupational therapy are key for maintaining joint flexibility, muscle strength, and hopefully allowing the patient to continue those daily activities of daily living when they're discharged. We want to perform regular range of motion exercises with these patients to prevent any contractures. So because they have that temporary paralysis and they're not able to independently move their joints, we want to do those range of motion exercises to keep the muscles strong and prevent contractures. Of course, we're going to do our DVT prevention on these patients since they are immobile. So they're usually going to have sequential compression devices, the FCDs on. And then emotional support is also really critical. These patients are like fully alert. So it's not affecting their like level of consciousness or orientation. So they are fully alert and aware of what is going on, but they're unable to move. So we really want to have like a calm, reassuring presence with really clear communication, letting the patient know what we're doing, why we're doing it. That can really make a big difference for them during their recovery. Okay. I am gonna take us out of that. And then let's see here. Okay, I just really quickly want to show you guys. I made a care plan example for you to look at here. See that. So I've been noticing as I've been looking at clinical paperwork that we are still kind of struggling with the care plans. They're looking good overall, so don't, I'm not coming for you or anything, but I just want to show you guys an example of a care plan. I know you only have one clinical left, but these aren't going away. They'll stay with you for the duration of nursing school, so I just want to make sure that you were comfortable making them. I did publish a video earlier on that's in the announcements if you want to look at that, but I just wanted to show you all this because it kind of helps us to look at a patient with Alzheimer's disease, but also showing you like what a good complete care plan looks like. So if you don't already have the nursing diagnosis handbook, it's one of the required texts for this course, so I hope that you have it, but if you don't already have that, make the investment to get a nursing diagnosis handbook because it will break all of this down for you. So our assessment data, this is just our subjective and objective data that we're looking at for our patient. So things that the patient or the family member said to us, things that we are observing about the patient, and then also our objective data. So like their vital signs, their laboratory values, our assessment findings on them. So for this patient with Alzheimer's, the patient is stating, I don't know where I am. The family reports irritability or anxiety when their environment changes. I did my assessment on them. They're A&O times 2. They can't recall the current date or location. And they have that poor judgment and safety awareness. So they keep trying to stand up without assistance despite weakness. Don't have enough time for this, but I wanted to show you guys like where I found all of this in your book. I do have the page numbers on here, so this is just specifically for the Alzheimer's patient, but the way this works with your nursing diagnosis handbook is you find at the beginning your patient's medical diagnosis. So when we're making our nursing diagnosis, we're not going to mention anywhere in there what the patient's medical diagnosis is. So I'm not going to say in here that my patient has Alzheimer's disease, or if your patient had like hypertension or congestive heart failure, you're not going to be mentioning that on this care plan, but you will look it up in the book and it will give you some ideas of what your nursing diagnosis can be. So in this case, I looked up Alzheimer's and I found this nursing diagnosis that I felt fit my patient. So chronic confusion related to loss of cognitive function as evidenced by patient not oriented to the current date or location. So this first part here, the chronic confusion related to loss of cognitive function, that's what was in my nursing handbook. And then I used my assessment data over here to put as evidenced by something over here that I feel is contributing to this nursing diagnosis. Okay. And then once I have my nursing diagnosis, I looked that up in the handbook. So flipped closer to the middle end of the book, found the nursing diagnosis. These were the 2 goals I found in my nursing diagnosis handbook that I felt would be best for my patient. So they'll remain content and free from harm for the duration of my shift. So I'm being time specific and it's reasonable, it's achievable. And then they will participate in activities of daily living at the maximum of functional ability during my shift. So I won't read through all of these nursing interventions for the sake of time, but again, these were all in the handbook. So these are the things that I am going to be doing with my patient, and I'm also explaining why I'm going to be doing these things with my patient. And then for the evaluation, when you're doing this part, you can either evaluate your 2 goals here, or you can evaluate your 5 nursing interventions if you were able to do those. But I feel like for the sake of time, just go ahead and evaluate your 2 goals here. So I said that my goal was met for my first goal. The client remained calm and content throughout my shift. They did not attempt to stand without assistance or remove their ID, and they remained free from injury. But then for my second goal of them participating in their ADLs, I said the goal was not met, and so I want to list how I'm going to revise that plan. So although the client is typically able to feed themselves, they did not eat their lunch during this shift. For the next shift, I will open the client's meal tray and prepare the food to encourage independent eating. So I'll go ahead and post this under the content for the weekly content on Blackboard, but I just feel like, oh, and also don't forget to include your reference down here for your book. I forgot that. Apologies. But I'll include this as an example. So again, these care plans aren't going away and you guys have really made great improvements. So you're doing great, but I wanted to give you another example there. Any questions on that? Okay, I know you guys are exhausted. We'll see you at 1 o'clock for a neuro lab simulation. Try to get some rest. I will post some exam grades. Have a good rest of your day.